But before we get to that Q&A section, I'll briefly talk about the four rectal or anal canal specific diagnoses that they want you to be aware of. So when we're talking about hemorrhoids, what they're really going to do on test is they're going to make sure that you know the different features between internal and external hemorrhoids. As we just talked about, an internal hemorrhoid is located above the pectinate line, whereas external hemorrhoids are located below the pectinate line. And here's the chart we just looked at where we have our internal hemorrhoids here and our external hemorrhoids here. And you can remember that because the external hemorrhoids, the name external just sounds closest to the surface. When we talk about innervation, it shouldn't surprise you that because you're above the pectinate line, you'll have visceral innervation. And when you're below the pectinate line, you'll have somatic innervation. And the reason why I wanted to point this out is that when you have visceral innervation, you're less likely to feel a sharp localizable pain. You'll feel more of that broad diffuse pain. And whereas somatic innervation, like if you pull a muscle in your body, you're going to have very sharp localizable pain. For that reason, if you take an external hemorrhoid, it's often going to be very painful or itchy because you're going to have that somatic innervation telling you exactly where it's hurting. On the other hand, internal hemorrhoids tend to bleed more, whereas external hemorrhoids tend to bleed less. In real life, you can obviously have an external hemorrhoid that's bleeding. You can also have internal hemorrhoids that are painful. But what I want you to know for step one is that they're going to keep this very straightforward to you. Internal hemorrhoids in your mind should just be non-painful bleeding. Those are the features of internal hemorrhoids. Whereas external hemorrhoids are going to be very painful, but they will not bleed. So keep this distinction in mind. And this shouldn't be difficult for you to remember as long as you remember the visceral and somatic innervation of anything above and below the pectinate line, this all should intuitively make some sense. Now let's briefly discuss anal fissures. So anal fissures are caused by tears in the anal mucosa below the pectinate line. And so this could be caused by a low fiber diet or constipation. So it's that repeated straining can cause some damage in this region. And so since we're below the pectinate line, we know that it's going to involve some sort of somatic innervation. And somatic innervation, if there's any damage to your somatic nerves, you're going to feel it. So it will be very painful. So in this case, you'll have pain while using the restroom. I just wanted to mention, in the case of anal fissures, because you actually have an anal mucosa tear here, you will often see blood when wiping. And something that's occasionally tested on step one, as well as it could be tested on your surgery shelf or step two occasionally, they like you to know that for anal fissures, the most common location for an anal fissure is the posterior midline. So if you look at your anal mucosa like a clock, it'll be that 6 o'clock position. And that's due to poor perfusion in that region. So I'll just quickly draw a diagram. If this is our anus here, and so if you look at it like a clock, so we have 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock, the most common location of an anal fissure here would be in the 6 o'clock position. And my mnemonic to remember this is that when you think of PU, like after you're using the restroom, you'll remember that it's the posterior location and it's under. That reminds me of the posterior midline right here. Let's move on to anorectal varices. So the pathogenesis of these, you'll have portal venous congestion or hypertension. All that portal congestion will back up in your portal system. And so you're going to get a backup in the superior rectal vein. Because there's a connection between your superior rectal vein and your middle and inferior rectal veins, some of that hypertension and congestion will be brought back. There's going to be a back pressure, which will start filling up those veins. Once these inferior and middle rectal veins become dilated, they're not going to be able to withstand these pressures because they're not used to having such high pressures in their small veins. And those veins itself can dilate and rupture, resulting in GI bleeding. And again, this is just caused by, this whole process will be caused by this vein here, this superior rectal vein, actually attaches to the inferior and middle rectal veins. And so if there's a back pressure here, you can get some of that congestion building up here. And so let me show you. This is a diagram I use when we talk about this in great detail. In the liver section, I go over portal hypertension and all of its complications. So what ends up happening, what I want to mention to you is the framework that we're going to talk about. In the portal system, we have all of our portal venous fluid drains into our liver, and that goes to our hepatic vein and into our IVC. On the other hand, systemically, you'll have your classic artery that becomes an arteriole. Those drain into capillaries, which drain into venules. Those go into large veins and ultimately into the IVC. So what I'm going to do now is I can actually simplify this. And we have our portal vein ultimately drains into our IVC, and all of our other systemic venules and veins also drain into the IVC. So sometimes in a few different regions of our body, we actually have connections between these two systems. And so in those settings, if you have a enlarged portal vein in the setting of like portal hypertension, what can happen is that they can transmit some of that congestion to your systemic circulation. And that's why it's called a portosystemic anastomosis. And again, this is from our liver section. I talk about the 3 clinical conditions that you have to recognize, the 3 anastomoses you have to recognize, including their venous supply from both the portal system and the systemic circulation. And in this case of anorectal varices, we've talked about the portal supply is our superior rectal vein, and all that congestion can be transmitted to these inferior and middle rectal veins. And so what that'll look like is you'll have your superior rectal vein becoming very congested, and that can transmit it to these other veins, and that can ultimately cause bleeding if these veins cannot handle these new dilations. Okay, so anorectal cancer is our last rectum-specific conditions we'll talk about. You can get squamous cell carcinoma if it's below the pectinate line, and it'll be referred to as an adenocarcinoma if it's above the pectinate line. And again, that shouldn't surprise you. That's the same thing we've went over earlier. If it's above the pectinate line, that means it's part of your hindgut, it's part of your embryologic GI tract. And so it should come as no surprise to you that any cancer in that area would be an adenocarcinoma. On the other hand, if it's below the pectinate line, it's not part of your embryologic GI tract. So it's kind of similar to your oral cavity or proximal esophagus in that regard. And so if there is a cancer that forms there, it's more likely to be squamous cell carcinoma because the predominant cell type in that area is squamous cells. So some risk factors they want you to know for the test. They want you to know that HPV is a very big risk factor for, especially for squamous cell carcinoma. Anybody who has anal receptive intercourse is at risk. It's essentially the same reason why you're at risk for squamous cell carcinoma in your esophagus. It's that repeated inflammation and damage. And so the same thing can happen in the setting of anal receptive intercourse where you have chronic inflammation and that can lead to cancer. Anybody who's immunocompromised is also at risk here. And the reason being that HPV, like we said, if HPV is a common trigger for squamous cell carcinoma of the rectum, then anybody who's immunocompromised might not be able to clear that virus as effectively. And so they'd be at higher risk as well. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.